Thank you very much for the introduction, and thank you for letting me to speak about my favorite subject, my femto phaco. We'll just give a very brief introduction again. The cataract is responsible for half of the global visual impairment all over the world. Improvement of the phacoemulsification procedure is needed, and still complications are major problems in the regular phaco, and I think we can make it less with the femtophaco. The femtosecond laser is now commercially available in for the three main steps: the capsulorhexis for sure, and the lens fragmentation, and the wound construction. We have the capsulorhexis. I think we've done that. The femtophaco, you know that this is a photo disruption of the tissues, and that's the plasma and the bubbles that are made are separating the tissues, and this what makes our life easy in capsulorhexis and fragmenting the lens. We have 3 or 4 platforms for this main platform. Of course, we have lots, but the main platforms that we have right now is our Lensex, Optimedia, Victus, and Lensar. The Lensex was the first commercially available femtophaco machine, and uses disposable curved patient interface. We call it a PI, patient interface. Uses optical coherence topography for the imaging, and is FDA approved for the capsulorhexis and phacoemulsification, and lately even for the flap formation. The Optimedia utilizes fluid-filled interface, not the applanation one, and uses a spectral domain OCT. Is the FDA approved for the anterior capsulotomy and lens fragmentation only. The Lensar utilizes the fluid-filled interface. It's how it's different from the others. It uses Chamflag principle, and it is approved for the anterior capsulotomy and lens fragmentation, and not for the refractive procedures. The Victus, on the other hand, has curved pressure sensing interface and is approved for the refractive as well as the cataract surgery. We have steps for the for the femtophaco. The programming first, you have to program the machine according to your preference. Actually, this 5.5 capsulorhexis is now, I think most of us will take like 4.8, sometimes 4.5 diameter for the capsulorhexis first, and then we have the eye docking, which is just similar to the refractive eye docking. We have to center the cornea so we'll have a central rhexis and central and proper wound at the proper site. And then we have the laser energy delivery. The current research now suggests that the femtophaco surgery will provide selective benefits, not all benefits, but selective benefits over the other for some patients. It has a learning curve, but this learning curve is shorter than most probably the refractive one. It has more complications in the beginning, especially when the hydrodissection is done. Maybe the wound, when you're doing the wound like Dr. Ammar showed us. The safety outcome are comparable, if not better, than the phaco. The software is still evolving. So in our Lensex, we have 4 upgrades in software in this last 6 years. So it's still evolving, and every upgrade has its own advantages. So it will make our life even easier. We cannot, if you ask me what is the most important step in the phaco and the femtophaco, it's the capsulorhexis. Capsulorhexis is undeniably more precise, and the size and the centration are much superior than the one you do with your hand, how experienced you are. I used to consider myself an experienced capsular surgeon, but actually after doing the FEMTO, you cannot do that. And you, as we heard before, this is very important in centration of the lens and effective lens position. If you make larger capsular axis, it means that you'll have a lens that's anterior, slightly anterior, and more myopic shift, and otherwise, if you have small one, we'll have the other way. If it's centered, especially if you do the multifocus or the toric, you'll have lens tilt, and then you'll end up with unhappy patient, as we heard. This was a study we presented in the ASCRS 2016, and we wanted to compare the FEMTO versus the conventional phaco, and we compared the BSS consumption, and we choose actually it was several items. We choose 20 patients. We did 10 by that method, and the other 10 with the other method. And all the patient was operated by one surgeon, same machine. The phaco machine was the same. FEMTO phaco was the same. BSS and all the patients were the same. In the phaco, conventional phaco, we used the fast shop machine. We didn't use stop and shop or this gutter procedure. No hydrosection was needed actually in the FEMTO phaco, which is, we presented as well this videos, we called it the magic bubble. After phaco, we don't have to do any hydrosection because this bubble by itself will dissect the nucleus from the underlying capsule. So we did it, and we presented in patients, several patients actually, and we proved that it can be done in every patient, especially in hard cataracts, but not, of course, if you have some capsular zonular problems. So the phaco power in both were about the same, let's say slightly less than the FEMTO, like 8% less than the FEMTO. The BSS consumption was less in the FEMTO rather than the BSS, like 20% less. The strikingly, the effective phaco time was much less in the FEMTO rather than the conventional one because you have softened nucleus. The endothelial loss was not that much actually, maybe in both of them wasn't that much. The corneal thickness was about the same. There's no difference between both of them. As a conclusion was the FEMTO phaco was superior over the conventional in corneal endothelial dense, but not that much. Reduced BSS, not that much. But the phaco time was much less. We have lots of studies. I don't know if you can go on for that. Lots of studies. This by Friedman showed that the centration of the capsular axis are much more superior than the manual one. Like here, you have 29 micron shift from the planned rather than the 337 micron shift. So this will lead up to less lens IOL tilt and superior refractive outcomes. The other studies by Nagy just compared the effective lens position and the power. It's all proved that the FEMTO phaco are much superior over the regular phaco. I know some of us are very skeptical about the FEMTO phaco, but actually at the end, this is the future of the cataract surgery. FEMTO are the future, especially when it improves lots. The corneal incision, I agree with Dr. Ammar, is not superior, much superior, but at least you can design your planned incision. The outcomes in this study show that it's more superior. We have to have transitions to go for the FEMTO. You have to have a proper dilatation, clear cornea. If you have corneal opacity, you cannot go for the FEMTO phaco. It shouldn't be glaucomatous. You have to have a cooperative patient as well. You have to have a wide palpebral fissure, not a very small eye. Otherwise, the docking will be very difficult. You have to communicate the patients all the time. The refractive surgeons know that. And we have to affirm the patients to reaffirm the eye position, so to avoid the tilt, to have to just center the cornea. So I think we went through the incisions and everything. So the other thing that I want to say that we have a financial problem with this one. It's if we're going to use it as a private business, this is it's not logic. But you have to shift because you have to change your setting in your clinic. You have to shift to a multi-physicians system, to get more physicians to work with you to get the benefits out of it. If you just depend on you to get your money out of this machine, of course it cannot be. So we have these studies about how many person you have to do it, and I think it was like each doctor has to have at least 700 patients per year to get it, and we have to have at least 5 or 6 doctors working with you. So in conclusion, the femtosecond laser is still in its babyhood, and same path was for the intraLASIK when it was introduced first. And it has evidence superiority, especially if you're using the prime IOLs, and competition between the machines will always provide us with better technology. Thank you very much for your attention.